Hi, my name is Dr. Peterson. I'm with the Department of Radiology at the University of Ottawa, and I'm going to talk a little bit about the review of chest interpretation as we see them on films or images that we take in our digital atmosphere. Now this is a picture of how we take a chest x-ray, and usually we take a PA and a lateral view of the chest, as you can see. On the image on your left, the patient is standing with her chest against what we call the image detector. And the x-rays come from her, behind her, pass through her back, through the front, and to the detector. Now, the reason we take it this way is because the heart lies next to the anterior aspect of the chest. And there's less magnification of the heart when the x-rays pass from the back through the front. The closer the image, the heart is to the film, the better idea we're going to get as to its size. Now, the second image you see here on the right is the lateral, how we take a lateral film. You can see that her left side is up against what we call the bucky or the image detector. So when we take this film, the x-ray comes from where I'm standing or you're standing, passes through the patient to hit the detector on the other side. Okay, so those are the standard ways that we take a view of the chest. Now we're going to talk a little bit about the normal chest x-ray, and these are the normal chest x-rays on this patient, and you can see that they're good quality. You can see the vessels almost everywhere, right in the midline. You can see the spine, the white part all the way through, and you can see the black airway. Now we're going to talk about a few of these structures on the next couple of films. So we're going to start with the PA view of the chest. And the first structure we're going to talk about is the inferior vena cava, or the superior vena cava. And here we've got an arrow. There's an interface here. There's a line that you can see adjacent to the mediastinum. On one side of the line is white, on the other side is black. Now the reason we see this line is because it's an interface between air and soft tissue. If there's no interface, if there's no air next to the mediastinum, we will not see the structure. So this line comes all the way down from the neck right to the region of the right atrium, and that line is formed by the superior vena cava. The next structure we'll talk about is this little almond-shaped structure, which is just above the right mainstem bronchus. This is the azygos vein. Now, the azygos vein is an alternate pathway for blood to flow from below the diaphragms up into the heart, and the azygos vein actually empties into the superior vena cava. Next we'll talk about the right hilum. On the right side, the pulmonary artery sits in front of the bronchus, and the two of them branch together out into the lung. Everywhere in the lung that you see a bronchus, you will see an artery, because they're right next to each other. On this right side, the two of them can be seen branching together out into the lung, and the artery is not separate from the bronchus on this view. Finally, we can see the right atrium here. You can see a nice sharp border where the right atrium sits. The airway you can see in the midline here, it's black. You can see it all the way down and to the level of the carina, where it bifurcates into the right and left main bronchi. The little notch here is formed by the aorta, which we can see in relief. And again, the reason we see the aorta so well is because there's air next to mediastinal soft tissue. This is the left pulmonary artery. On the left side is different from the right in that the pulmonary artery goes up and over the mainstem bronchus, which is here. So the black part is the bronchus, the white part above the bronchus is the left pulmonary artery. And finally, the lower border of the heart is formed by the left ventricle, and that forms that border right there. Now anytime you see a chest x-ray, you should look for these different structures The more you see, the more you'll be able to recognize. Anytime you have consolidation in the lung, you're going to lose some of these borders. Now we'll go on to the lateral chest film, and a lot of medical students and doctors tend to avoid the lateral film because they find it difficult. But if you concentrate on the airways in the center, which you can see here, this is the trachea coming down, and you can see where it bifurcates down below, then you can describe the structures in front of and behind the trachea. This is the right pulmonary artery. The right pulmonary artery, I told you, sits in front of the airway on the right side. And this forms a big white blob on the lateral film, which is about the size of your thumb. The heart border on the lateral view that's in front is the right ventricle. You should always look, it shouldn't be more than about a third of the way behind the sternum. If it's bigger than that, then the right ventricle is enlarged. This white area here is formed by the arch of the aorta, and you can make it out just very faintly, but it is a white area that can be quite distinct. This other white area here is the left pulmonary artery, and the left pulmonary artery goes up and over the bronchus here. Now this is the bronchus to the left upper lobe, which we see as a round hole end on. The pulmonary artery sits above it, and you can see the white area above that bronchus. The left atrium is the part of the heart that sits here, and all the pulmonary veins form a confluence that comes into the left atrium at that level. And finally we have the left ventricle, which sits in the lower part of the chest. Now you have to look at the diaphragms wherever you are. The right diaphragm is the one here that goes all the way to the front. The left diaphragm comes to the front but stops at the level of the heart. The reason we don't see the anterior aspect of the left hemidiaphragm is because the heart sits on top of it, and there's no air between the diaphragm and the heart, so we don't see the diaphragm at all. So the right diaphragm is the one that goes all the way to the front. The left one is the one that stops at the heart. Now I want you to look at the spine as well. If you go down the spine, you'll see that it gets blacker from the top to the bottom. This is normal. When you have an area of consolidation, this will change. Finally, you look at the retrosternal space. The retrosternal space should be uniformly black. Okay, now we're going to talk a little bit about some diseases of the lung, and we're going to start with consolidation. Consolidation just means simply solid lung. It means lung that is no longer containing air. It is of soft tissue density. So it's not going to look the same. Now there's two types of consolidation. There's consolidation that occurs without volume loss. That means the volume of the lung is maintained. And conditions that cause this are pulmonary edema, pneumonia, and hemorrhage. In these conditions, the air spaces are all filled up with fluid. There's no volume loss, but it is soft tissue density. Then we can talk about consolidation with volume loss, and this is called atelectasis or collapse. And there's certain signs of volume loss that I'm going to show you. This is a diaphragm illustrating airspace consolidation without volume loss. On your left side, you can see a normal airway. You can see the major airway going down into these peripheral air spaces. Around the peripheral air spaces is some fine interstitial tissue, and amongst the interstitial tissue are fine capillaries. This is where the oxygen exchange takes place. This is where oxygen goes into the small blood vessels and carbon dioxide comes out. Now there are also some interstitial spaces besides the parenchymal interstitial space that holds these air sacs apart. One is called the bronchovascular interstitial space, and then there's a subpleural interstitial space. Both of these are important in pulmonary edema, and we'll describe them later. Now on your right side is a diagram of what happens when you have airspace disease. all of those air spaces fill up with some kind of fluid, whether it's pus or hemorrhage or just edema. This is what happens, and you'll notice that there is no volume loss. However, this area of consolidation is soft tissue density, and that means that the interfaces that have formed in your lung between air and soft tissue will no longer be visible where there is consolidation. Consolidation with volume loss looks like this, okay? So on the left side is the normal, and on the right side we can see that there's solid lung, there's soft tissue inside the air sacs, but there's also volume loss in that the lung is collapsed. So consolidation means solid lung. Here we have a patient who has a nodule in her right lower lobe period. I performed a lung biopsy on this nodule, and after that she coughed up a lot of blood. She had hemorrhage into the air spaces around the nodule, and this is a form of consolidation, which you can see here. Now you'll notice that there are little white speckled areas which we sometimes see at the very periphery of an area of consolidation, and these are called acinar shadows. We also notice that there's an area of increased soft tissue density, and that's what happens in consolidation. Thirdly, you'll see that the diaphragm immediately adjacent to the area of consolidation is completely gone. In other words, we can't see it. We can see the diaphragm central to the area of consolidation and into the costophrenic angle beyond, but right where the solid lung is, we cannot see the diaphragm, and this is called a silhouette sign. One of the other changes we look for in consolidation with airspace disease is an air bronchogram. Now here I've shown a lobar pneumonia, and you can see the bronchus coming out into that pneumonia and branching. Those black branching lines are called an air bronchogram, and that is another characteristic of airspace consolidation. This is a patient who has a pneumonia in the left upper lobe. Can you see what borders are missing here? We can see the left hemidiaphragm, we can see the right hemidiaphragm, we can see the right heart border, but the upper portion of the left heart border is indistinct, it's blurred. We cannot see the hilum either, and we've lost the arch of the aorta. This is because there's solid lung next to those structures. Now if you look very closely, you can see a black branching pattern in the upper lobe area, and this is an air bronchogram. These are all signs of consolidation, and there is no volume loss here, so this is probably, or could be, a pneumonia. So first of all, we're going to talk about consolidation without volume loss, and this is also called airspace. So here we go. If we look at this particular area here, we look at a chest x-ray, we can see this patient's normal chest x-ray on the left side, but on the right side we have lost the diaphragm. Okay, we've lost it completely. If you look through the heart, you can tell that there's white stuff back there, and this is consolidation. There's an air bronchogram going down there. There's no volume loss, so this is what a left lower lobe pneumonia looks like. If we go to the lateral film on the normal side, you can see the right hemidiaphragm, which goes all the way to the front, and the left hemidiaphragm, which goes to the heart. However, when we look at the left lower lobe pneumonia on the right side, you can see all of the right diaphragm, but you don't see any left diaphragm. That's because there's consolidation on top of that diaphragm. There is solid lung on top of there, so we've lost the interface between air and soft tissue. Okay, what border is missing here? Well, we can see the left hemidiaphragm and the left heart border. Can we see the right heart border? I think so. I think you can see a black line around it on the PA view of the chest. However, we can't see the right hemidiaphragm. And there's a branching black pattern in there that represents an air bronchogram. So on the basis of the PA view, we would say that this is probably a right lower lobe pneumonia. Now we go to the lateral film and we see one diaphragm there. This diaphragm sort of stops at the heart. That's the left diaphragm. So where's the right diaphragm? We can't really see it. If we go down this